So now I would just play a small video by Dr. Vinod Agarwal. He's not here, but he was kind enough to record his presentation and share it with us. His presentation is on, I think I'll let him speak. Volume maximum. Volume, please.
Hello everyone. First of all, I'd like to apologize for not having been able to attend this wonderful meeting. And I would be thankful to Dr. Chakitan and his whole team for having me as a part of this instruction course. Now, while we have heard a lot about benefits of OCTA, I think we should be aware of the other aspect of the OCTA as well. So I'll be sharing a few cases of mine where OCTA helped, rather not helped, and made the things complex. Now, just to introduce a bit, we know that this technique of dye-less angiography, and that is OCTA, is a very promising technique. It has several advantages over fluorescein angiography in terms of being non-invasive. It is repeatable. It gives us the retinal vascular anatomy layer-wise. That is, it resolves the retinal vascular plexus in various depths, and of course, to a certain extent, it is quantifiable as well. But as we are aware, all roses come with thorns. So is OCTA. It has its certain disadvantages. So I'll show you some of my cases where OCTA rather made the things more complex. Now, this is the first case. If you see carefully, this is a typical case of macular telangiectasia type 2 in a 58-year-old female. You can see there is a small graying in the temporal macula, and there is a right angle venule, which you can see on the fluorescein angiogram as well. And you can see the leakage in the temporal macula. OCT shows the outer layer abnormalities, and OCTA of the right eye does not reveal any CNV complex. Now, have a look at the other eye. You can see there is a pigment plaque in the temporal macula, and just superior to the pigment plaque, there is a grayish lesion. And you can see the typical temporal leakage on fluorescein angiography in both the eyes. And in the late phases of FA, you can see a small hypo fluorescent spot, which is just above the pigmented plaque. Now on OCT, you can see the pigment plaque causing shadowing underneath on your left side, while the scan through the supratemporal grayish lesion does show some amount of thickening overlying it. Now, when we did OCTA in this patient, we could find small neovascular complex in the outer retina. Now, since patient was asymptomatic, we did not do and just followed up this patient. And this neovascular complex, as you can see in the below picture, it is at 2 years. It is increasing in size, but the patient remained asymptomatic. And this is at 3 years. Nothing changed much apart from that small increasing size of CNV complex on OCTA. Now, this is a classical case where OCTA will show you a few vessels either in the outer retina or in the choriocapillaris complex, and we wouldn't know what to do with it. So this is a patient if you explain to the patient will be more anxious, and surgeons or the physician, of course, would be on his toes to see when this CNV complex will become active. So, in nutshell, OCTA will detect certain CNV, which will lead to unnecessary follow-ups and anxiety on both patients as well as physicians' perspective. Now, this is my second case. If you see, this is a patient where the left eye is normal in the pictures below. On the pictures above, you can see there is a small hypoautofluorescent spot in the central macula, and on OCT through the central fovea, you can see there is a subretinal fluid. Now we went ahead with the FAICG in this particular patient. You can see on FA there is some stippled hyperfluorescence, which gradually increases mildly in the later phases, while ICG does show some hyperfluorescent vessels in the center of the fovea, which again show a little bit increase in the late phases. Now, I was doubtful about the diagnosis of CNV, so I went ahead and see, and you can see there is a very nice little complex of CNV which is seen on OCTA as well. So this patient underwent 2 injections of uh, Avastin with no response. Then he underwent one Eylea. Again, he did not respond or responded only very minimally. So at this stage, we thought probably there is no neovascular complex, and it was just probably the RP atrophy which is causing the choriocapillaris to peep in from underneath, and that's why we could see this neovascular complex on OCTA. So we went ahead and did PDT for this patient, and you can see the fluid nicely resolved. Patient throughout remained stable subsequently, and again you can see on autofluorescence that there is hypertrophy of the retinal pigment epithelium. So, to conclude, this case teaches us that not everything which you see on OCTA is actually CNVM. It may just be a window defect which is peeping through a RP and thereby leading to a wrong segmentation. Coming to case number 3. Now, this patient is very, very interesting. If you see, this patient is a myopic middle-aged female, and you can see there is CNV in the center. On FA, there is a questionable leakage, and we know that there is always minimal leakage in myopic CNVMs. And OCT, again, you can see there is a sub RP CNV, and with again very questionable fluid which is there on the OCT scan. We did OCTA in this particular patient, and you can see there is a very nice little membrane which is sitting there. Now, going back to the history, when we took history from this patient, this is what is the history of the patient, that she received 2 anti-VEGF injections uh, for this particular lesion, and the last injection was 6 months back, and since then she had been asymptomatic. Now that is very, very important because even the regress CNV you may see on OCTA, and it is very important to take into account the clinical features of the patient and the symptoms of the patient before you go on to decide with the treatment. So again, we learned from this case that all CNVMs on OCTA do not need treatment, and clinical details of the patient are paramount in deciding the future course of the disease. This is my fourth and the last case. You can see this is the patient who presented to us with a vascular mass on the optic disc, which could be seen on red free photograph as well. Octa very nicely highlights this vascular mass, and we made a diagnosis of hemangioblastoma on optic disc surface, and you can see on B scans of OCTA also you can see this vascular mass which is lying in the superficial retina. Now, uh, when we did FA of this patient, so you can very clearly see that of course the evident superior mass is there, but there is a small infranasal hemangioma as well. Now, if you go back to our color picture, now you can see that there is a very faint reddish mass which is there, which has been missed on all the images, including OCTA, but has been picked up very nicely on fluorescein angiogram. So to conclude, we have a limited experience with Okta as of now. Some of the obvious disadvantages at this point of time include smaller field, and since many forms of retinal vascular lesions lie in the retinal periphery, so they are very difficult to be picked up with Okta. Lack of leakage is an obvious drawback over fluorescent angiography. And just as you saw in the last case, subtle lesions may not be picked on OCTA at times. OCTA, of course, requires a longer capture time as compared to fluorescent angiography. So problem thereby in certain cases, for example, foveal aplasia. You just cannot capture the foveal avascular zone with the help of OCTA because of the pendulum nystagmus, but can be easily done with the help of fluorescent angiography. So basically, OCTA is a evolving technique. It is very promising, but it has several advantages as of now, and I'm sure as we progress with time, the technology will become better and we will be more uh, apt at interpreting this particular technology. As of now, I would just mention that single caution that you have to interpret each and every image with caution. And before you make a decision based on OCTA, please sit on the machine and go through all the scans as well as the OCTA B scans to decide the future course. Thank you very much. I'll stop here.
Thank you so much. I think we had good interaction, and please come up with questions if there are any more. And just one thing I needed to add, when you have a OCTA with you, please sit on the machine yourself and evaluate the lesions. Don't depend on the technician. So if the technician, like OCT, you can still depend, that they can give you a printout and you can see the printout and that's over, but not for OCTA, because you'll have to enhance the image, you'll have to segment the image, you'll have to see different layers. The technician or the optometrist or even a junior doctor cannot do that for you. So you have to sit yourself and have a look at it.